What is going on, everybody? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my cardiology playlist. In previous videos, we talked about angina and myocardial infarction. We discussed the different types of shock, such as cardiogenic shock, obstructive shock, hypovolemic shock, neurogenic shock, septic shock, and anaphylactic shock. We talked about rheumatic fever and infective endocarditis. We discussed myocarditis and pericarditis, pericardial effusion, cardiac tamponade, congestive heart failure, broken heart syndrome, systemic hypertension versus pulmonary hypertension, cyanotic congenital heart diseases versus acyanotic congenital heart diseases. As for today, we shall start a new series on valvular heart diseases, such as aortic stenosis, aortic regurgitation, pulmonic stenosis, pulmonic regurgitation, mitral stenosis, mitral regurgitation, tricuspid stenosis, and tricuspid valve regurgitation. Click the like button, click the subscribe button because I'm already feeling dizzy. This is my cardiology playlist. It has videos on cardiac anatomy, cardiac physiology, cardiac pharmacology, and pathology. Quick review on the normal blood circulation in adults. Oxygenated blood leaves the lungs and goes to the heart through the pulmonary veins into the left atrium, and then the blood leaves the left atrium and goes to the left ventricle through the mitral valve, which is the only heart valve that is made of 2 cusps only instead of 3. Then the oxygenated blood is going to leave the left ventricle and go to the aorta through the aortic valve. This oxygenated blood will be distributed to every organ in your body. The cells will extract the oxygen from the arterial blood, use that oxygen for internal respiration or cellular metabolism, and then dump the waste products and the carbon dioxide onto the venous side. These veins will return the deoxygenated blood back to the right atrium. Then the deoxygenated blood leaves the right atrium and goes to the right ventricle through the tricuspid valve. Then the deoxygenated blood is pumped from the right ventricle to the pulmonary trunk through the pulmonic valve, and the deoxygenated blood reaches the lungs. The lungs will exhale this carbon dioxide, inhale some oxygen, and give it back to the left side of the heart, and you continue again and again and again. Where is the mitral valve? It's between the left atrium and the left ventricle. Normally, it allows blood to go from the left atrium to the left ventricle during ventricular diastole, and then it should close during ventricular systole to prevent the backflow of blood from left ventricle to left atrium. If you wish to see more cardiology videos like this in the future, drop a heart emoji in the comments. So how many cardiac valves do we have? The answer is 4. There is the mitral valve between left atrium and left ventricle, tricuspid valve between right atrium and right ventricle, aortic valve between left ventricle and the aorta, pulmonic valve between the right ventricle and the pulmonary trunk. Each one of these 4 heart valves can have pathologies. Pathologies could be stenosis or regurgitation. So there is aortic stenosis and aortic regurgitation, mitral stenosis and mitral regurge, pulmonic stenosis and pulmonic regurge, tricuspid stenosis and tricuspid regurge. What's the difference between stenosis and regurge? Stenosis is difficulty at opening. The valve did not open properly when it should open properly. What is regurgitation then? It is insufficiency. The valve cannot close properly. So failure to open is called stenosis, failure to close is called regurge or insufficiency. Let me ask you a question. When is the aortic valve supposed to open? Is it during systole of the ventricle or diastole of the ventricle? Let's think about that. The aortic valve is supposed to open when the left ventricle is contracting, i.e. during systole, in order to allow the blood to pass from the left ventricle to the aorta. And that's why aortic stenosis, which is difficulty at opening, is a systolic murmur. How about aortic regurgitation? Aortic regurgitation is difficulty at closing. But when is the aortic valve supposed to close? It is supposed to close during ventricular diastole to prevent the backflow of blood from the aorta to the left ventricle. So if it was supposed to close during diastole, therefore failure of closure is a diastolic murmur. Aortic stenosis is a systolic murmur, whereas aortic regurgitation is a diastolic murmur. Next, mitral stenosis. When is the mitral valve supposed to open? The mitral valve is supposed to open during ventricular diastole to allow blood to pass from the left atrium to the left ventricle. Failure to open during diastole means that mitral stenosis is a diastolic murmur. Conversely, mitral regurgitation is difficulty at closing. When is the mitral valve supposed to close? During ventricular systole to prevent the backflow of blood from left ventricle to left atrium. During systole, therefore, mitral regurgitation is a systolic murmur. And then when you play the same game, the pulmonic valve, just like the aortic valve, is supposed to open during systole. That's why pulmonic stenosis is a systolic murmur, whereas pulmonic regurgitation, difficulty closing, the pulmonic valve is supposed to close during diastole to prevent the backflow of blood from pulmonary artery to the right ventricle. That's why pulmonic regurge is a diastolic murmur. Tricuspid is similar to the mitral. If mitral stenosis was a diastolic murmur, tricuspid stenosis is a diastolic murmur as well, whereas tricuspid regurge is like mitral regurge and is a systolic murmur. The moral of the story is the aortic is identical to the pulmonic, whereas the mitral valve is similar to the tricuspid valve. How do I remember that aortic stenosis murmur is systolic, that mitral stenosis is diastolic, that aortic regurge is diastolic, and mitral regurge is systolic? There are two methods. Method number one, that of understanding, and method number two, that of memorization, the mnemonic. Let's start with understanding. You know it. Aortic stenosis is failure to open the aortic valve. When is the aortic valve supposed to open? During systole. Therefore, aortic stenosis is a systolic murmur. Mitral stenosis, failure to open. When is the mitral valve supposed to open? It was supposed to open during diastole. Therefore, mitral stenosis is a diastolic murmur, etc., etc., etc. This is method number one. Method number two, the memorization. You only need to memorize one inappropriate word, and this word is ASS, which means donkey, of course. Aortic stenosis is a systolic murmur. That's the only thing that you need to memorize, and then everything else can be deduced. How can I deduce everything else? Well, here's the rule. If you change one letter, you flip systolic once into diastolic. But what if I flip both letters? Then you're gonna flip systolic twice into diastolic and back to systolic. Let's practice. Aortic stenosis is systolic. Therefore, if I change the aortic to mitral, so the A became M, this is only one letter that has changed. So you change the systolic once into diastolic. All right, what if I change the other letter? The A will be kept constant and the stenosis will become regurge. Then you're going to flip the systolic once into diastolic. But what if I change both letters? The A became M and the stenotic became regurge. Therefore, you change systolic twice, which is like rotating 360, and you end up exactly where you started, also systolic. That's how you do it. And then the aortic is equivalent to the pulmonic. So if aortic stenosis is systolic, pulmonic stenosis is also systolic. If mitral stenosis is diastolic, then tricuspid stenosis is diastolic, because the mitral valve is equivalent to the tricuspid valve. Aortic regurge is diastolic, so pulmonic regurge is also diastolic. Mitral regurge is systolic, so tricuspid regurge is also systolic. Let's practice this one more time. You just memorize this word. Aortic stenosis is systolic. What if I change one letter? Mitral stenosis is diastolic. I flip 180 from systolic to diastolic. Let's flip the other letter. Instead of aortic stenosis, it's now aortic regurgitation. So you flip systolic once into diastolic. But what if I flipped both letters? Aortic became mitral and stenosis became regurge. Then you're going to keep the systole as is. Mitral regurge is systolic. Then aortic stenosis is the same as pulmonic stenosis, which is systolic. Mitral stenosis is the same as tricuspid stenosis, which is diastolic. Aortic regurge is like pulmonic regurge, which is diastolic. Mitral regurge is similar to tricuspid regurge, which is systolic. Suppose that my aortic valve is narrow. It is stenotic. Stenosis means the valve is narrow. It's failure to open. It was supposed to open during systole, but it did not open properly. This increases the pressure on the poor left ventricle, and we call this pressure overload. Whenever there is pressure overload, we're going to develop hypertrophy of the left ventricle. Okay, what kind of hypertrophy is this? Since this is pressure overload, it is going to be concentric hypertrophy. And whenever there is pressure overload, you're going to hear an S4 heart sound. But what if I have something like pulmonic regurgitation? Oh, regurgitation, the blood is coming back from the pulmonary trunk to the right ventricle. This is volume overload. And volume overload causes what? It also causes hypertrophy of the right ventricle this time. And what kind of hypertrophy? Since it's volume overload, it's eccentric hypertrophy rather than concentric hypertrophy. And since it's volume overload, we expect S3 gallop rather than S4 gallop. Please remember that stenotic murmurs cause pressure overload, whereas regurge murmurs cause volume overload. And there is another thing that we need to talk about. For whatever reason, anytime there is dilation of a chamber, for example, we have right ventricular dilation, for whatever reason, this dilation is gonna dilate the annulus of the tricuspid valve, making it very difficult to close the tricuspid valve when it should. And this is a very important rule, which is dilation equals regurgitation. Dilation of a chamber causes regurgitation of a valve. Again, as we have discussed before, if there is volume overload or increased preload on the left ventricle, it shall undergo eccentric hypertrophy and we expect S3 heart sound. The regurgitating murmurs such as aortic regurge and mitral regurge can lead to S3 heart sound because of the eccentric hypertrophy because of the volume overload. When the ventricle is dilated, as you see here, this ventricle is good at diastole, receiving blood, but bad at systole, pumping blood. And if the left ventricle is bad at systole, all of this excessive blood will pile up in the left atrium, then in the lungs, leading to pulmonary edema and in some cases even pleural effusion. I'm just talking about the left ventricle as an example, but it could be any chamber of the heart. Conversely, if there is pressure overload, also known as increased afterload, this causes concentric hypertrophy. And this happens with stenotic murmurs like aortic stenosis, mitral stenosis, etc. Also, in cases of hypertrophic obstructive cardiomyopathy or hypertrophic cardiomyopathy, as opposed to the dilated cardiomyopathy, which has more volume overload. I have talked about the different types of cardiomyopathy in separate videos. If I have pressure overload or increased afterload, we expect S4 heart sound. By the way, if you want to review the anatomy of the heart, check out my anatomy playlist. I have review videos for each subject in anatomy, such as anatomy of the head and neck, upper extremities, lower extremities, anatomy of the thorax, the abdomen, the pelvis and perineum, neuroanatomy, and even embryology. Each one of these topics is covered in 3 separate videos. So when it comes to anatomy of the thorax, there is part 1, quick review, part 2, ultimate review, and part 3, clinically oriented anatomy of the thorax, including anatomy of the heart. Stages of mitral regurgitation, or any valvular heart disease for that matter. Mitral regurgitation, just like any other valvular heart disease, is divided into 4 stages. Stage A, Stage B, Stage C, and you will never imagine Stage D. Stage A, patient is at risk of mitral regurge. Stage B, patient has progressive mitral regurge. Stage C, severe yet asymptomatic. Stage D, severe and symptomatic. The normal heart sounds are S1 and S2. S1 heart sound is the lub. S2 heart sound is the dub. Lub dub, lub dub, lub dub, etc. Between S1 and S2 there is systole. Between S2 and the following S1 we have diastole. So if a murmur is systolic, such as aortic stenosis, then you will find the murmur here. What if the murmur is diastolic, as in aortic regurgitation? Then you will find it here, between S2 and S1. While using your expensive stethoscope that you used to brag among your friends while your parents are suffering financially, when you put your stethoscope onto the patient's heart, and you happen to hear a murmur, how can you tell whether the murmur is systolic or diastolic? You need to time it. How do I time it? Here's your clue. You put your fingers onto the patient's pulse. Okay, it could be the carotid pulse or the radial pulse. The pulse coincides with systole. So if you hear a murmur while feeling the pulse at the same time, then this is a systolic murmur. But if you hear the murmur and then later you feel the pulse, it's a diastolic murmur because the pulse happens with systole. Next, where do we hear the murmurs? First, you need to know the areas of auscultation of the heart. There is A1, or the first aortic area. There is A2, or the second aortic area. There is P2, or the pulmonic area. Then we have the tricuspid area and the mitral area. So it is APTM. APTM. aortic, pulmonic, tricuspid, and mitral. Aortic, pulmonic, tricuspid, mitral. Aortic, pulmonic, tricuspid, mitral. The first aortic area is in the right second intercostal space near the right sternal border, because that's where the aorta is. Pulmonic area is in the left second intercostal space near the left sternal border, because that's where the pulmonary trunk is. Tricuspid area is at the left lower sternal border, usually in the left fifth intercostal space near the left sternal border. You could also hear it in the left fourth intercostal space. As for the mitral area, it is the same area as the apex of the heart. And where is the apex of the heart? Assuming that you do not have dextrocardia, the apex of your heart is in the left fifth intercostal space mid-clavicular line. The clavicle is here, mid-clavicle. This is exactly where you draw the apex. The apex is roughly half an inch below the patient's left nipple. But be careful, because the size of the female breast is variable, so therefore we cannot simply rely on the location of the nipple to auscultate a female patient's apex. Some textbooks make a huge mistake. They say the apex is 3.5 inches lateral to the sternum. This is a load of bilge water. Why? Because some patients are obese, some patients are slim. Some patients are young, children. Some patients are adults. So 3.5 inches away from the sternal border is utterly unreliable. What is always reliable is mid-clavicular line. Because if I'm a big person, my clavicle is big and the mid-clavicular point will coincide with the apex. If I am a slender, tiny person, my clavicle will be tiny and the mid-clavicular line will coincide with the apex of the heart. The mid-clavicular line is your guide, not the distance from the sternum. How about the second aortic area then? The first aortic area is in the right second intercostal space, but the second aortic area is in the left third intercostal space. What can we hear at the first aortic area? The murmur of aortic stenosis, which is pathologic. The flow murmur on the aorta, which is physiologic. By the way, physiologic murmurs are always systolic and never diastolic. Physiological murmur is synonymous with innocent murmur. If you want to learn about the different causes of flow murmur, these are the same causes as of hyperdynamic circulation, also known as high output cardiac failure, and I've talked about this in detail in a video titled High Output Cardiac Failure. What can we hear in the second aortic area, which is in the left third intercostal space? Aortic regurge as opposed to aortic stenosis. Why is this? Think about it this way. Here is the lovely aorta, okay? Stenosis means the valve is narrow. So the blood encounters difficulty while passing through the narrow aortic valve, and you will hear the jet of blood that was capable of passing here, because the narrow valve creates turbulent flow, and you can hear turbulent flow with your stethoscope, but you cannot hear the laminar flow. But what if I have aortic regurgitation? Well, the blood is coming back. It's coming back from the aorta to the left ventricle. As it comes back, you're gonna hear it here at the left third intercostal space. See, medicine makes so much sense once you understand what the French toast you're talking about. Where do I hear the murmur of pulmonic stenosis? In the pulmonic area, which is in the left second intercostal space. How about the murmur of pulmonic regurgitation? In the left third intercostal space. For the same reason, because regurge means it's coming back, it's coming back, it's coming back, so you're gonna hear it here. One type of HOCM, hypertrophic obstructive cardiomyopathy, is called idiopathic subaortic stenosis. Subaortic, below the aorta. That's why you're gonna hear it here in the left third intercostal space. What can I hear at the tricuspid area? Tricuspid regurge, tricuspid stenosis, and VSD. What can I hear at the mitral area or the apex of the heart? Mitral regurge, mitral stenosis, and mitral valve prolapse, which causes mitral regurge. If ventricular septal defect is heard here, for obvious reasons, is that blood is flowing from the left ventricle to the right ventricle, so you're gonna hear it here. Where do we hear the murmur of atrial septal defect then? It has to be at a higher level compared to the VSD, and this higher level is in the pulmonic area or the left second intercostal space. How about the murmur of patent ductus arteriosus? It's here. It's infraclavicular, below the left clavicle. Here is S1, here is S2. Between S1 and S2, there is systole. Between S2 and the following S1, there is diastole. Mitral regurgitation murmur, just like tricuspid regurge, is holosystolic or pansystolic, unlike mitral valve prolapse, which is usually mid-systolic. Has anyone watched the previous video? Mitral stenosis was diastolic murmur. This is S1. This is S2. Between S1 and S2, there is systole. Between S2 and the following S1, there is diastole. So the murmurs that you find here are the systolic murmurs. The murmurs that you find here are diastolic murmurs. The murmurs that you find in both are continuous murmurs. What are the systolic murmurs? The holosystolic or pansystolic murmurs that involve the entire duration of systole include ventricular septal defect, tricuspid regurge, mitral regurge. The first two are heard over the tricuspid area or the left lower sternal border, whereas the mitral regurge is heard over the apex of the heart. Next, the crescendo-decrescendo murmurs include aortic stenosis and hypertrophic obstructive cardiomyopathy. Crescendo means going up, decrescendo going down in intensity. The murmur of aortic stenosis usually has an ejection click before the murmur. This click is early systolic, not to be confused with the mid-systolic click that you find in mitral valve prolapse. And because mitral valve prolapse can later cause mitral regurgitation, it's a click followed by a murmur. If I have a prolapse without regurgitation, I will just have a click, a mid-systolic click. But what if I have a mitral valve prolapse and mitral regurgitation? You will have both a click and a murmur. Mid-systolic click followed by a late systolic crescendo murmur. Next, the diastolic ones. Aortic regurgitation is a diastolic decrescendo murmur, and it starts at S2. The mitral stenosis is characterized by an opening snap that starts after S2, followed by a late diastolic rumbling murmur that gets louder and louder and louder, and it ends with pre-systolic accentuation until it culminates with a very loud S1. As for the patent ductus arteriosus, because your ductus arteriosus is patent during systole and during diastole, it's a continuous machine-like murmur. It is more loud during systole compared to diastole. It becomes the loudest around S2 heart sound. I asked one of my students one time to describe the murmur of patent ductus arteriosus, and the student answered, "It's a washing machine-like murmur." Well, why does it have to be a washing machine? It's just machine. Students these days. So let's review valvular heart diseases. The history. The patient usually has rheumatic fever or a rheumatological condition such as rheumatoid arthritis or systemic lupus erythematosus, endocarditis, whether it's infective or non-infective, calcifications of the valve or congenital anomaly in the valve, such as the bicuspid aortic valve. I have separate videos on rheumatic fever, rheumatoid arthritis, lupus, endocarditis, and more. See my cardiology playlist and my rheumatology playlist. Symptoms. Many patients are asymptomatic. Some patients have palpitations. Some patients have symptoms of low cardiac output failure. Some patients have symptoms of pulmonary edema and pulmonary congestion, etc. Physical exam findings, the murmurs by your stethoscope. And here is a rule for you. Anytime you hear a murmur using your lovely stethoscope, the next logical step is to do an echo, preferably with the Doppler, to look at the flow as well as the anatomy of the valve. We do EKG because sometimes there is chamber enlargement and axis deviation. Cardiac catheterization is usually the most accurate, but it is invasive, whereas echo is not invasive. But I think echo is invasive. What is it invading? Your privacy? Get out of here. How should we manage valvular heart diseases? Non-pharmacological management includes diet, usually low sodium diet. Exercise is important. Depending on the disease and the symptoms, pharmacological treatment can help. For example, if we have symptoms of congestive heart failure, we can give diuretics. And then, when there is a problem in the valve, we can do surgery. You can repair the valve, or you can replace it with a new valve. If you replace it with a new valve, you have two options. You can replace it with a tissue valve, or you can replace it with a metallic valve. The tissue valve usually comes from a pig or another animal, and this is called bioprosthesis, whereas the metallic valve is called mechanical prosthesis. Each one has pros and cons. Diuretics, nitrates, beta blockers, and ACE inhibitors can be beneficial. Learn more about these medications as well as the anti-hyperlipidemics, antiarrhythmics, antihypertensives, anti-anginal medications, and digoxin by downloading my cardiac pharmacology course at medicosisperfectionalis.com. Learn about angina, myocardial infarction, the types of strokes, cardiac arrhythmias, ARDS, acute limb ischemias, the toxidromes, and more by downloading my emergency medicine high yields course at medicosisperfectionalis.com. Learn about cardiothoracic surgery, vascular surgery, neurosurgery, trauma surgery, orthopedic surgery, general surgery, and more by downloading my surgery high yields course at medicosisperfectionalis.com. Each one of my courses comes with videos, notes, and cases. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.